Our next speaker is Dr. Fairooz. I think she doesn't need any introduction. She is a great oculoplastic surgeon, currently working in her specialty eye care in Bangalore. And she is also a member of scientific committee or India Ophthalmological Society. So Dr. Fairooz, please. Here.
Hi everyone, good morning. Thank you Dr. Chandna for having me here. It's a pleasure and honor, and this is my first presentation in AIOC. Amazing cases on eyelid lesions and eyelid masses. So what I'm going to talk to you here today is a very interesting topic that ma'am thought about. Tissue is an issue. All right. What do you think when she thought about why should tissue be an issue in eyelid tumors? Is it an issue? Yeah, so that means histopath is very important, right? Histopath is very important in many aspects in eyelid tumors. In fact, tissue should not be an issue. We should get enough tissue because eyelid lesions, unlike like small conjunctival lesions, you get enough tissues, right? But as a practicing ocular oncologist, as an oculoplastic surgeon, what we should make sure is that there is no recurrence in these lesions, and for that, one, diagnosis. Second, it's also therapeutic, right? Tissue is therapeutic, and that's exactly what I'm going to speak today. These are my affiliations and my financial disclosure. I'm going to take you through a story, all right? This is a case, a 64-year-old patient, okay? She presented, she said, I feel a lump, and she was being treated as chalazion elsewhere. Now, when you see this picture, even me, I don't know which eye it is, whether it's right eye or left eye. I told her, okay, do you want to look down? Maybe some bumpiness is there in the eyelid. Nothing at all. She said it's in the left eye. Okay. I'm like, okay, fine. She's like, I'm feeling slightly better, but there was a swelling, and she's been treated as chalazion by a general ophthalmologist. Well, voila. So it's so very important always to avert the eyelid. Okay, so on aversion of the eyelid, this is a lesion which is very plaque-like, flat, yellowish in color, lot of vascularity. You can see that this tumor, there is extension, invasiveness into the margin. Okay, although there is no lash loss over there. Well, very, very, very typical of a sebaceous gland carcinoma. All right, yeah. So now what do I go? I go ahead thinking that I should get a clear margin. So that is why tissue is so very important, okay? Now, I went ahead with wide margin eyelid excision under frozen section control, and that is what I do in my practice. We'll discuss about that. Okay, so usually in my practice what I do, and this is mainly posterior lamellar, right? Anterior lamellar is absolutely fine in this. So I went 4 millimeters on either side, okay? And after the first frozen section, in fact, I send in the frozen section, although this is kind of a very diffuse and plaquic, there is no congestion even over here. I got a positive margin here. I got a positive margin again, medially. So that is why tissue is so very important. If I would not have done a frozen section, if I would not have checked, whether there is positive or negativity, although clinically it looks, amazingly fine, this patient would have recurred. Okay, and almost, this much of the eyelid is gone now. Recurrence, dealing with the recurrence is so very difficult. So very important to identify that the margins are negative before you reconstruct in any malignancy. Whereas sebaceous gland carcinoma is more of a bad malignancy, lethal malignancy. Okay, we have malignant tumors like Dr. Anirban told about basal cell carcinoma, squamous cell carcinoma, sweat gland carcinoma, but there are 3 lethal malignancies of the eyelid. Okay, I would go according to the chronological order of severity. Merkel cell carcinoma is the worst, followed by melanoma of the eyelid, and third is sebaceous gland carcinoma. And why? Because regional lymph node metastasis and systemic metastasis is high. Okay, so I went ahead again. excising. In fact, a lateral margin was excised, reconstructed upper lid with a flap from the lateral canthal, relaxation. And this is how she is. I just saw her recently, follow up 18 months. She was fine. PET scan was within normal limits. Now, basal cell carcinoma, we all know that we saw it can be really diffuse. We call it like a rodent ulcer, right? There is a lot of extension. Although you feel that the margins are well defined, it can extend and extend. And this is one of the case where I had excised twice. One frozen section positive, second frozen section positive. And finally, from here, this patient landed up, losing the entire eyelid. So tissue is so very important for us. So the options that we have is frozen section, or empirical excision. Now, well, some people say we don't have the facility, so how do we send it for frozen section? Let's do empirical excision, just clinically. So that's why I highlighted those two cases over there. So when you don't have a frozen section, okay, these are the indications. What I would suggest, so this is why frozen section is very, very important, because what you see is just probably the tip of the iceberg, because it's invasive, it's like crab-like. You may have tentacles of this malignant cells going deep inside into the margin, but clinically this might be the margin, but this would be pathological margin, and that's why so important it is. Now, another option is the Mohs micrographic surgery. In my practice, I don't have a Mohs surgeon. I'm not a Mohs surgeon, so I don't do Mohs surgery. But in United States of America, there's a lot of Mohs surgeons who does Mohs surgery also. Now, what would I suggest? I understand I have studied in a government medical college as a postgraduate. We don't have all the facility to send for the frozen section. If you are running your own practice, I run my own practice. I don't have a pathology in-house. Okay, so but still I make sure I send my specimen to a pathologist who's sitting in another lab somewhere in another institute, and still I do it. So that is one option. If not, you can go for a wide margin excision. There is no hurry in closure. Okay, you can send it to a pathologist in your institute, expedite it. Just call them and keep asking. 2 days, 3 days. Can you just give me the report? Don't close it. But once after you get the fix-it section report that your margin is fine, then please close it. So that is the third option. So tissue is very, very important. I'm just going to take you through this video, how we take the tissue for any eyelid tumor. This is a very typical sebaceous gland carcinoma. Clinically, we identify the margins, okay, in the operating table. So this is basically the margin, and from the margin, we take 4 millimeters. All right. Now 4 millimeters medial, lateral, inferior. Most importantly, sebaceous gland carcinoma especially is a posterior lamellar tumor. So you have to have 4 millimeters posterior lamellar also, just not anterior lamellar. All right. And then you mark it. Sometimes you might have to compromise puncta. You can try to retain it if at all possible. Now then traction is given. Okay. Traction everywhere, and then wherever the marking is, you excise it. Okay, anterior lamella and the margin. So this is how it includes the margin, the posterior lamella and the anterior lamella, and then you put it in a filter paper, mark it, and then send it to the pathologist immediately, and then the pathologist tells you. Yeah, so this is reconstruction. I'm not going to go through that. All right, so these are how the margins are taken. With the marking, it's very, very important, and this is how a fresh sample is wrapped in a saline gauze. No formalin, just wrap in a saline gauze, put it, mark it, stitch it if you think it is wobbly, and then send it to the pathologist. All right, yeah. So we wait it out. Initially I do it under local anesthesia, and if I need a big reconstruction, then I do it under general anesthesia in the second procedure. So the patient is waiting in the ward, and this is how it looks. So even a larger excision, you can get very good reconstruction. Now, why is it so important? I'm just taking you through a few cases. This was an empirical excision without margin clearance. The patient recurred after 3 months. All right. Second case, this patient recurrence post-empirical excision biopsy without margin clearance twice. So this is the third time that the patient came with me. She was referred finally after 2 recurrences, like kindly handle this, okay? But it was all empirical excision. Now, this is a bad case, empirical excision biopsy without margin clearance. When he came to me, recurrence 2 times, 1 month and 3 months, and this is what he had. a large tumor. In fact, I excised it. It came as poorly differentiated carcinoma, possibly granular origin. So there is a sebaceous gland carcinoma which can become aggressive after recurrence into a poorly differentiated carcinoma, where the chances of systemic metastasis, regional metastasis is much, much higher. Well, in fact, we could get a clear margin in this. BC, basal cell carcinoma. Sometimes people cheat on basal cell carcinoma thinking, well, it's not too lethal, so let's kind of not do a margin and it's going to be fine. But this was a small lesion, still it recurred in her, all right? And then she had to go for further excision. Now, this was a patient who had a cystic lesion where she was punctured. She said that doctor used a needle because it was cyst, punctured, and then but it grew back again. Okay, now you know what it came out to be? Endocrine mucin producing sweat gland carcinoma. You see these large blood vessels, as Dr. Anirban showed you, all the features to differentiate between benign and malignant. If there is a minimum suspicion of malignancy, make sure that tissue is not an issue for you. You have to go take the tissue from there and make it sure that you diagnose it. Okay, so again I went for 4 millimeters excision, and this is how she is. So our frozen section control, mandated, yes, we did a study, and that is how we always fear of recurrence. So in that, what we found that margin involvement had larger rate of recurrence. Okay, so this is how, where it was performed and not performed, 37%. Literature review also says the same. Now, map biopsy, again in eyelid malignancy, especially sebaceous gland carcinoma, is very, very important. And yeah, neoadjuvant chemotherapy is given to chemo reduce the tumor in order to get a good margin during excision. So this is a textbook that I have been part of as an author, which explains the eyelid tumors and stuff. So standard of care in eyelid malignancy has to be excision with histopathological confirmation. Margin status, if it is unknown, avoid closure reconstruction. And very, very important, never do an eyelid sharing procedure if the margins are not proven negative. Okay, thank you so very much. So tissue should not be an issue. Thank you.
Thank you, Dr. Fairooz, for that excellent elaborative talk. Issue, actually, I thought the title is so catchy, so people at least should come and so.
It's a nice title.